I flew out of Dubai at 3:30 a.m. this morning, so I'm a little food too. So we're going to talk about clinical evaluation, clinical examination of a female patient. I'll obviously do the PT part and Dr. Shyam will do the psychological. And I'm going to skip through things that we don't need. This is a question I was often asked: what's going to happen on my first visit when I come to see a women's health physio? I'm going to go, I want to hear about everything that's happened to you, not just about what's going on right now, because you are how you are because of what's gone on in your life. Again, I'm going to be more focused on history of falls, TMJ, temporomandibular joint dysfunction. I want to know a lot and everything about how much they pee, how much they poop, and how much they have sex, and how they do it. Start to flow of urine. Who's crooked? If they have leakage when they laugh, cough, jump, or sneeze. And again, any history of any diagnosed urgency, recurrent UTIs, frequency, or stress incontinence. Bowel function is pretty much the same thing. I want to know how they poop, when they poop, and what it looks like. I know, it's such a fun thing. My patients always tell me, I tell you more than I told anybody else ever. I want to know if they have any pain with bowel movements, if they have difficulty evacuating, that really push and strain to go. Both with bowel movements and with bladder function gives me a good sense, and it's taking me along the path of what's looking at the bowel or incomplete emptying or straining. I'm going to ask again for a functional assessment of what sex is like. What was your first intercourse like? Have you ever had sex? What was your first intercourse like? What's the frequency of intercourse if you're active? When was the last time you had it? When did you have pain? Did it start right away, or has it been just recently? Could you not use a tampon when you first tried to use a tampon? First time you tried to touch yourself, was it painful? First time you tried to have sex, did it hurt? What about your orgasmic status now and in the past? Oftentimes I would ask early on in my questioning, do you have orgasms? And they say, oh no. And then as we go on along, oh gosh, yes, I do that 3 times a week. Do you have an orgasm? Oh, sure. But that's not the same. She doesn't feel that that's like having an orgasm with her partner with penetrative intercourse, as we all know, this is what we do. That doesn't typically happen. We need that stimulation of the clitoris to get that arousal button going. Tool I've ever had. This is probably the 5th one I've had. It's quite old and very heavy, but this helps them understand what is going on physically inside the pelvis. This is the pelvis. Spine goes up the back, 2 joints in the back where the pelvic bones come around, and the sacroiliac joints, with the sacrum and the coccyx coming down from there. We flip you over to the front. The pubic symphysis is the joint in the front. There are 2 layers of muscles, pelvic floor muscles. There's superficial pelvic floor muscles and there are deep pelvic floor muscles. The superficial pelvic floor muscles almost make a triangle of support around the vaginal opening, and then continue in a figure-8 pattern to go down to form the external anal sphincter, and that then connects to the tip of the coccyx. So this is a very small, supportive, most exterior, superficial pelvic floor muscles. We'll see pictures of these later. If we take this off, the muscles are much bigger and broader. They go from the front all the way on either side of the pubic symphysis, around and attached to the base of the coccyx. This is the sling muscles that we hear talked about a lot. There's a big difference in structure and there's a big difference in function. So after showing this to my patients, I would then do my exam. They knew where I was going, they knew what I was doing, because they could see that this is the anatomy and know what was there. So it was a really great tool for me to be able to use. I also did talk with them about the location of the organs, where the urethra, the bladder, the uterus, and the bowel were. We'll talk about that in just a second. This is from John Delancey. It's not just the pelvic floor muscles, but everything from the parietal peritoneum down to the external pelvic floor muscles, which includes the uterus, the bladder, the urethra, and the rectum, fascial structures of the support of the pelvis, the levator ani, fascial support of the levator ani, and the arcus tendineus, as well as the bony structures and the pelvic floor muscles. Because it all operates together. It doesn't operate on its own. The pelvic floor muscles don't just stand there all on their own. They're tied in with all sorts of other things. So the function of the pelvic floor muscles, just in general, there are 4 functions that we talked about, that we talk about more than anything. They help to support the organs, to prevent prolapse, because when organs fall out, they're really not very pretty. They help control urination, defecation, because they contribute to the sphincters of the bladder and the urethra, and the bladder and the bowel. They contract and relax with orgasm, or not, as we heard earlier, but they contract and relax with orgasm. And the pelvic floor muscles, along with the abdominals and a couple of muscles up the spine, is truly the base of our core support. So these muscles are really, really, really important in overall functioning in everything that we do with our core. It's the first set of muscles that react when we go to move, or when we get scared, or when we're anxious. So from my perspective, the pelvic floor muscles in all of this are nothing but a symptom of something else, not a cause of a problem. When the superficial pelvic floor muscles are overacting, they slightly close off the opening of the vagina. The arrows show where those pressures come and go in, just minorly closing the external vagina, the external vaginal opening, let's put it that way, right at the introitus. If we go on into the deep pelvic floor muscles, and again, you see the force on the vagina here. When there's overactivity in the deep pelvic floor muscles, the much bigger, broader set of muscles, they really contract up and can hold tight. But then they should be able to release and let go. We'll talk more about that tomorrow. Or on Saturday, sorry. So just briefly, I really like to show this because if you made a plane across ischial tuberosities, these are the sits bones, the ischial tuberosities. If you made a plane across here, a normal position of the perineal body with normal tension and tone is going to sit just superior to that plane. If the pelvic floor muscles are underactive or lax, the perineal body is going to sit outside of that plane, inferior to that plane. The size of the vaginal opening is going to be much larger than when it's normal. But when you have women with pain from whatever reason, whatever the cause, that pelvic floor, that deep pelvic floor muscle squeezes in, holds tight, totally decreases the size of the vaginal opening. And these are the gals when they lay down on your table with their knees up and you say, oh, where is the vagina? And you kind of have to dig to go because it's pulled so far up and into the pelvic bowl. So when you lay it down on your table and look, you can tell whether or not she has pelvic floor muscle tension, overactivity, just by where the perineal body sits with reference to those ischial tuberosities. I do a modified Q-tip test. The Q-tip test is the gold standard for identifying vulvodynia. I do it because I'm getting ready to take my fingers on the inside, and when I do that, I take a look at pain sensitivity at 3, 6, and 9 o'clock at the opening of the introitus. I put my finger there, I wiggle it around a little bit, and I ask for 0 to 10 pain. What's no pain? 0 is no pain. 10 is the worst pain ever. What does this feel like right here? Because that superficial sexual pain is where this happens the greatest. Then I do an internal assessment. And again, I talked about the organs. I'm really quite interested in what's happening at all of the viscera inside the anterior pelvis. So if I do my assessment on the outside, I then turn my finger over. And at 12 o'clock, just inside the vaginal canal, is the urethra. And if the urethra is there and it's nice and calm, it feels like a mound of tissue. However, if there's overactivity in those longitudinal and circumferential muscles of that urethra, it feels like a pencil in there. And it can cause urgency and pain and discomfort. That's not normal. You shouldn't be able to make any. I don't have it in here, but I also then checked with the periurethral fascia on either side of the urethra because that fascial tension can cause a lot of problems. I think on the bladder, I slide my finger up just a little bit further. When I teach physios to do this, they always say, well, how do I monitor the bladder? I said, well, it's the end of the urethra. There's nothing else to be there. If you come up and it feels like a cotton ball, you can hardly palpate it, you can hardly feel it, that's normal bladder tension. There's no urgency, there's no pain, there's no burning when you touch it. However, if you come up and you touch it, and it says, ooh, that's not comfortable, ooh, that hurts, that burns, that makes me feel like I need to empty my bladder, that's an abnormal tension. That's abnormal tension in that bladder. That's not normal. And all of those things that I'm talking about can cause pelvic floor muscle overactivity. There's a really nifty spot right on the backside of the bladder called the trigone, which is really highly innervated. And I oftentimes use that spot as a general myofascial release to help release tension in the pelvis as well. Then I'm going to, if I can, I'm going to put 2 fingers, and when I'm able, I get 2 fingers into the vaginal canal because I want to find the cervix. We know that the cervix hangs on that huge broad ligament and should swing free in the breeze, right? So when yeah, it really should. I put my 2 fingers in and I mobilize the uterus to see that it goes equally right to left and anterior to posterior. Because oftentimes with deep penetrative pain, you've got a uterus that's stuck. And if the uterus gets stuck, if the cervix gets stuck on the bladder, or cervix gets stuck on the rectum, for whatever reasons, from maybe endo issues, from scarring, from whatever the case, deep penetration hitting that cervix is going to hurt. Because typically, it's flowing in the breeze and it moves out of the way. The rectum is really quite simple. That's at 6 o'clock. I turn my hand over. Same thing as with the urethra. If it just is a large amount of tissue, that's normal tone. But if it causes gas or pain or I feel like I need to go to the bathroom, that's abnormal. But a rectum, when you go in, that's really bulky and big and bumpy, with no urge to do anything, it's probably just full of stool. So this is what happens when I find abnormalities in all of those organs. If there's tension in the muscle and the organs and the fascia for that matter, it can cause incontinence, like urinary bowel dysfunction, incontinence, urgency, frequency, perceived constipation. It can cause sexual dysfunction with dyspareunia, amenorrhea, aporuria or vaginismus, chronic vulvar pain. It can cause definite difficulties with vaginal exams. You've got somebody that you can't see the vagina, if you can't see the opening to the vagina, chances are if you shove a speculum in there, they're not going to be very happy with you about that. Inability to use tampons, and sometimes with superficial pain, there can be problems with fighting with clothing choices. Women can't wear underwear, they can't wear pants, they can't ride a bicycle, they can't ride a horse. So, a fully functional history really helps me to begin to understand what's going on and where I need to go with my treatment. All of my treatment is manual. That's what I do. I'm a physical therapist. The unfortunate thing is I'm here in this lovely, wonderful country where physios, I understand, are not very well trained, and there are no women's health physios in the country, which breaks my heart. It makes me very sad, and I wish I could do something about that. So all of this is what it is. Pelvic floor muscle abnormalities, whether overactive or underactive, can contribute to issues related to sexuality, bladder function, and pain. And function matters. Our organs need to have the tone that they need to function, and the muscles in and around that need to be functioning normally, and the fascial issues need to be calm. And when they are, everything is happy. That's a shame.
Especially when I talk to people about sexuality or sexual health. So here we go. Wiggle, 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 right hand, left hand. Right leg, left leg. Wiggle, 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 wiggle. Wiggle, wiggle, wiggle. One more time, and the last time. Wiggle, wiggle, wiggle. And as you stand, I want you to take deep breath and calm yourself down. One more time. And now we are ready to listen. We are ready to learn something very, very important, and it's going to help you in your clinical practice. And not only for investigation, assessment, also for your treatment goals. So now please let's sit down. Wonderful presentation. And that was all about anatomy, physiology, and the functional aspect. And what I bring to you today is the psychological aspect, or I should say the holistic assessment and examination of a female patient. Especially, we talk about not just any female patient, we talk about patients who come to us with sexual problems, right? We're especially talking about sexual problems. So this is me, not much, but I have no disclaimers today. This is a small little graph which helps you when a patient comes with sexual problems, right? This is a nice flow chart. Really see it, read it at your leisure. But today, I'm going to give you a very beautiful algorithm. And this algorithm is going to help you throughout your clinical practice, not only to assess, diagnose, but also to reach to some clinical goals, treatment goals. So we talked a lot about history, we know history. We've learned all throughout our MBBS, MD, everywhere. History taking, we know. We know that we need to talk about the chief complaints, we need to talk about medical status and psychological, a lot of things. We've talked all day long. So what are the various evaluation tools, right? Three main evaluation tools are present. Very popular one is the present model. Dr. Reddy has spoken about it. I don't want to speak a lot. There's another model which is the Neves model, and Neves model is a holistic model which talks about the mind, the emotion, the body, the energy, and the spirit one brings. Right? We all are composite of all these different aspects. So the mind is our thoughts, our fantasies, emotions are how we feel. Okay, the body are the various body elements, the body image issues, the energy, what this person brings in that relationship, what this person brings during that sexual activity, and the spirit. The spirit is, so what does spirit mean, right? It's not just spirituality. Spirit means, again, an aspect of what you bring in a relationship. So one of the very common was visit model. We talked. There is Neves model by Dr. Patty Brighton, and there is Allow model. And just recently they came up with another model, which is mindfulness model of sexual health. So let's not go deep because I don't think that we all use it, but I want to give you something else which you are going to use. There are screening tools always available online. Okay, so this is a triangle. And when we talk today, we're going to talk about partner sex, right? We're talking about a partner or a relationship. So on the top is one partner. And the second pole is the second partner. And the third is your relationship. And why this is important is triangles are the most strongest structure in the world. Okay? And if you want your relationship to be strong, it has to be equilateral. Okay? So when we talk about this one patient who comes to you with a complaint, let's not just focus on this patient. We talk about the partner, right? And we talk about their relationship. So in any relationship, it's very important that that partner has to give significance to himself or herself as well. Okay? The second pole is the other partner. So the partner is also supposed to be looking after what this person needs, what this person wants. So it's a give and take relationship. And then both these two poles are connected to the last pole, which is the relationship. So for example, if we have a patient who's only just giving, right? This female patient is just all that I'm giving. She's not really concerned about her pleasure, her needs, her desire. This is called an exhaustion. Okay, the person gets really exhausted. At the same time, if this person just keeps on receiving, the other person is going to get exhausted and this is not going to be a fun relationship. Now, this person takes care of himself, herself, this person takes care of the other partner's needs of the other partner. The last point is if you don't take care of your relationship. Imagine, you say, of course I take care of myself in this relationship. Of course I take care of my partner. But what you're missing is a very important aspect in a relationship is the relationship. Right? So what are you doing for your relationship? Are you spending time with each other? Are you nurturing your relationship? Is there intimacy in this relationship? So this becomes a very important thing. Okay, this relationship, this complete triangle, if it is balanced, if it's equilateral, can make any relationship very, very strong. So when a patient comes to you, just don't stick asking about that patient, about that problem. Do inquire about the partner. Do inquire about the relationship, and this will help you to come up with different strategies in your treatment. So one aspect is this. Now the second model, we all know about the biopsychosocial model, right? We all are comprised of this model. We are all about our biology, we are all about our psychic, and we are all about social. But there are other aspects which were recently added. So along with the biology, the psychology, the socio-cultural, there is sexual and spiritual. So what does all this mean? So if a patient comes to you, right, you definitely want to take a detailed medical, surgical, all those history, which is the biology, the hormonal history, to rule out what could be the organic cause. The other aspect is the psychology. Is this person happy? Is this person suffering from depression? Any type of mental illnesses? So that is the psychic aspect. What does this person think about sexuality? What does this person feel about this relationship? What does this person feel about his partner or her partner? And what significance or what does this person feel about this relationship? Okay? That is the psychological aspect. Social cultural aspect, very important. We are also driven by our social cultural surroundings with all the negative messages which has been ingrained to us since we are children. So the social cultural aspect plays a very important role. I still remember this couple who came to me, and we kind of went on evaluating, investigating this couple, and we didn't know what's really going on. But both of them had severe intimacy issues. The husband was suffering from erection issues. The wife had no desire. The husband comes and complains, "Oh my God, and my wife is never ready." Now, when you go deeper into what is the social cultural aspect in that country, we got to know that they were living in a joint family, Islam followers. So they had different types of prayers, and we had to really go deep into their daily schedule to figure out, so what can we do that these people have private time and they can be intimate. So that's how you go deep in this aspect of social culture. Then there is the spiritual aspect, right? You need to find out, so this person has come to me, what is this person's spiritual beliefs? What is this person's spiritual practices? Right? So if I have a friend who constantly complains, my wife is never ready. Why? She does Somvar ka Shivji Upwas. She does Saturday as Hanuman Upwas. She does Thursday Sai Baba Upwas. She is never available. So what are the spiritual practices? So a patient comes to you, you must evaluate the patient also on their spiritual aspect. And then we have the sexual aspect. Is the partner suffering from some sexual problems? Right? Does this relationship have some sexual dysfunction? So please remember to assess the patient on all these 5 domains. Now, we all know about Dr. Mason's intimacy sexual response cycle, okay? And we all know that there are different aspects to a sexual response cycle, which starts with desire, arousal. Some people can absolutely have spontaneous desires. Some people can, with the help of a stimuli, can really lead into arousal. Then they go into orgasm and a resolution phase. And that is with each person. Now, when I put this algorithm together, so the takeaway message, we can discuss about that later, but what they talk about is sexual response cycles should not be goal-oriented. It's a pleasure-based response, sexual activity, right? There's no rush, there is no must to have orgasm. One should enjoy the company of their partner and their relationship. But let me put this entire algorithm together where when a person comes to you, even if she's a female or a male, comes to you with sexual problem, we need to tackle each point in a whole, and that gives an holistic approach when we are assessing, investigating, and also coming up with treatment. At any point of time, you miss the other 2 poles, you might find that your treatment is not holistic anymore. So if you are just treating one partner and the other partner has some other sexual issues, you'll realize that this whole paradigm is going to collapse. So you need to focus focus. So let's focus on the first point, is that this partner, if she comes to me, am I investigating a biological aspect? Am I investigating a psychological aspect? Am I investigating a social cultural beliefs? Am I investigating her spiritual beliefs? And am I investigating the sexual belief? Well, I've done that part. But still, I don't think so I've done a good job. Because if she's suffering from vaginismus, and if I haven't really asked questions about the other partner, this treatment is not going to really solve the issue. So even if you treat this person's vaginismus, sexual pain, you treat any aspect, if the other person has maybe a biological component, maybe a psychological component, maybe a sexual component, maybe the person has some social cultural beliefs, which is going to hamper the sexual intimacy or sexual problem, create sexual problem in this relationship, this again, your treatment is going to collapse. So remember, each domain, whenever you assess, don't really be stuck with scales, don't really be stuck with models, but make sure 5 domains is obstructing or blocking the sexual response cycle of the patient or the other partner, your treatment is then going to really collapse. So you need to focus, because see, the thing is, you're not really going to treat the cause. So you need to remember this particular diagram, and I can assure you, if you ever miss, if you carry this diagram always, you would never miss any domains. You will be able to really pinpoint, okay, this is what this person is suffering. I think it is a religious cause which is obstructing their sexual response cycle or causing sexual dysfunction, or they are not giving enough time in their relationship. So please, this is a very important algorithm to keep in mind. Rest, we've talked since morning, evaluate, take detailed history, look into the hormones, which is the biology, look into the mental status, everything. Lab testing we've discussed, and there are various other testing, again, to rule out pathology, which is the biological aspect. Take-home messages should be, make sure that your assessment, your evaluation and investigation and treatment of a female sexual concerns are in holistic, multidimensional. It needs to cover all the dimensions which we just discussed. It also needs to be focused, that it should be multifocal. So just don't be stuck with one aspect of the chief complaint, but treat this patient holistically. So definitely you can help not only this patient but the couple, and you can save their relationship. And the last, always make sure you discuss the various benefits of sexual intimacy in a relationship and how this can make the relationship much stronger. And I'm not here to talk about only married relationship, but I'm going to talk about any relationship in your life. So be the physician who really empowers your patients, encourages them and enriches them for having physical intimacy. Lastly, thank you so much for your patience.
Thank you, ma'am, for enlightening us. I invite Dr. Venkramana sir.
Did you all enjoy the workshop, guys? Yes. So if the workshop is so fabulous, you can imagine how the main conference will be. Tomorrow we'll be starting in time. Whatever little glitches that we had today, those glitches won't be there tomorrow, I assure you. There are chairpersons for tomorrow's session sitting in the audience. Guys, I do not want anybody to overstep the time because we are really short of time tomorrow. It's a marathon session throughout the day. We'll request each person to keep the mobiles on side.
Today's workshop has come to the end. At this juncture, I feel it is worth calling Dr. Ashwini, come here please. We are all in charge today. She has done a wonderful job. Thank you very much. Give her a hand.